I'm Pedro Delgado from the Institute for Healthcare Improvement, and it's great to have you here. I must start by asking you for a little bit of leeway. This is in some ways a PDSA. Our speakers, I don't think, have ever done a Pecha Kucha, so this will be quick, rapid fire, and they've asked me to tell you that they will be up front at the end of the session for questions, so we won't take any questions from the floor. If you're not familiar with this, it's rapid fire. The slides will advance automatically, so it requires quite an amount of coordination and synchronicity and so on. So please be kind to our group and our team. I have to tell you a couple of things as we introduce this session. This is one of the most generous groups that I have ever met in terms of knowledge exchange, in terms of story sharing, and in terms of having the will and the openness to be absolutely frank with each other. We spent half a day together on Monday, just reflecting on things. They coached each other for the whole afternoon. It was absolutely brilliant. The other thing that we wanted to do was to invite you in. If you are in a mental health organization anywhere in the world, and you think you can learn with us as a group, as a network, please come to the front at the end of the session. We're growing very organically. It's a very open group again. And we have people from Singapore, from Spain, from England, from Denmark, and from Scotland. So without further ado, I'm going to introduce Choon, who's the Chief Executive of the Institute of Mental Health in Singapore.
Thank you, Pedro. Good morning, everyone. Let's start with some questions. So how safe do you think mental health care is? Do we know when we harm our patients? Do our treatments cause more harm than good? And are mental health systems able to pick up all the adverse events that occur in our care? Well, let me tell you that harm and adverse events in mental health care are not uncommon events. They're often unintended, of course, but they're also under-recognized and they're under-reported. Many are often not even recognized by our patients, but may result in prolonged hospitalizations and add to the stigma of mental health care. And they definitely significantly affect our patients' experience of care. My name is Choon, and I'm from the Institute of Mental Health Care in Singapore. IMH is Singapore's only tertiary mental health care provider, and we're responsible for providing tertiary specialist mental health care to our whole population of 5 million people. Our patients expect the best care, and it's our duty to provide care that is safe, reliable, and effective. We have a long history from the 1920s when we were built as a British mental asylum, which provided mainly custodial care for patients and long-term care. But we have progressed to become a modern mental health facility, providing recovery-oriented care, providing patients with empowerment to look after themselves and recover. As you can see, we have a full range of clinical services in all the subspecialties of mental health care. On top of this, we have been, over the last few years, developing community-based services for different sectors of our society, our youth through our schools, and the adults and elderly with mental health problems through our home-based teams as well as outreach programs. As you can imagine, our patient load is high. So just in 2015 alone, we saw 40,000 different individual patients at our outpatient services. And we had close to 9,000 discharges or hospitalizations from the hospital. We are a big hospital, and bad things can happen. But if we are able to detect harm, we can prevent them. So how do we detect harm in our hospital? Well, there's always the traditional methods of voluntary reporting, although we do know that voluntary reporting systems merely pick up 20% or less of all the adverse events that happened. There's always comprehensive case file reviews, but we do know that takes a lot of time and is very intensive. So is there a better method? We turn to the Global Trigger Tool method invented by the IHI. It's a system where a list of triggers or clues are looked for in medical records to indicate the presence that harm or an adverse event has occurred. IHI has defined an adverse event or harm as an unintended physical injury resulting from or contributed to by medical care that requires additional monitoring, treatment or hospitalization, or can even result in death. But we realized that just using a tool like this doesn't suit the needs for mental health care. In mental health care, we have certain events that do not result in physical harm, such as self-injurious behaviors or attempts at self-injury, aggressive behavior or experience of aggressions from others, which may not again result in physical injury. Sometimes there are physical or sexual assaults, and certain behaviors like absconding or unauthorized absence from the ward may not necessarily result in physical harm. So we set ourselves up to develop a mental health trigger tool for use in our settings as an instrument to effectively identify harm or adverse events in a mental health setting and to be able to monitor our rate over time. This is how we went about it. We started, of course, with literature review, looking at the various trigger tools that had been developed, and we convened a local focus group to try and come up with a list of triggers. We also had an advisory panel, which included Helen, Carol Harridan from IHI. She was very helpful. We used a modified Delphi panel to vote on triggers that we would want to include in our list. And we had an initial list of 50 triggers, which we tried on 115 case notes. Well, we found that 50 triggers on one list was too many. It took too long, and some of them were duplicative. So we've pared that down, and we had a final list of 25 triggers that we did a validation study on 515 medical records. This is how we did it. We selected medical records of patients consecutively discharged from our hospital just 1 month prior to our study. We took all adult patients and patients who were hospitalized for less than 90 days. We, of course, excluded incomplete medical records, but those were quite few in our series. The next thing we did was we applied our list of triggers, 25 items to check against the trigger tool. We used 2 stages. The first stage was using 2 non-physicians to do this, checking the medical records to see if any of these words had been written down, which might suggest an adverse event had occurred. The second stage was a physician who decided whether an adverse event or harm had indeed occurred. So this is our findings. We found that almost 18% of all our patients had experienced at least one adverse event. Of course, these were not severe events. Some of them were very mild, but we wanted to include them. And they included a lot of adverse drug events, some patient injury, hospital-acquired infections was a surprise, as well as ECT-related adverse events. Then we looked at the type of specific events to mental health care. We talked about those, and we found that 11% of our patients in our study had experienced at least one mental health patient safety incident. Again, some were mild and some were more severe, but they were exposure to disruptive behaviors and aggression, self-harm, and abscondment from the hospital. So what have we learned? Well, we've learned that it is possible and feasible to develop a trigger tool for mental health. We realized, of course, that doing this resulted in some apprehension and worry among staff and management. You see, we were going to uncover things that we were not doing so well. And we also required a dedicated and trained group of staff to regularly do this if we're going to keep it going on an ongoing basis in our hospital. But you see, now we have a baseline, and we're sending our data up for publication and peer review. We will need to maintain longitudinal data on adverse events rates for our hospital and use this data to improve the care for ourselves and for our patients. Just leaves me to show you that this work was not done by a few people. It was done by a whole multidisciplinary team, which included the psychiatrists, clinical psychologists, pharmacists, case managers, and nurses. And on behalf of the team, I thank you for listening to us.
Next up, we have Maria Luisa. Maria Luisa is the Chief of Quality and Safety at the Parque Sanitario San Juan de Dios in Barcelona, Spain. So I presume she might get some requests to go and visit her. She's more than happy to host you. But Maria Luisa, the floor is yours.
Thank you. Good morning, ladies and gentlemen. Thank you for the opportunity to present our work to this Magnifica forum, especially to Institute for Health Improvement, East London Trust, and Healthcare Improvement Scotland. Parc Sanitari Sant Joan de Déu is a health institution located just outside Barcelona. The institution was a psychiatric hospital in the 19th century, evolving into a trust today that provides public service of the community focused on mental health care and general hospitalization. The mental health service provided include acute and long-term hospitalization, psychiatric forensic units in prisons, and outpatient centers. The hospital activity includes 1,500 discharges in acute mental health service and 172,000 visits to the outpatient centers. Our catchment area in acute mental health service is 700,000 inhabitants. The park carries out quality control and improvement and patient safety following guidelines from the Department of Health. For us, quality improvement means designing and redesigning process and system in order to deliver healthcare with better outcomes. Our most recent strategic plan defines for the first time objectives in patient-centered care, effectiveness, transparency of outcomes, and patient safety. A small centralized team was created, Quality and Safety Unit, supported by a network of healthcare professionals dedicated to working on projects. The Quality Unit works by giving support to the direction of management team and working with other units. Currently, our work of quality and safety is being reorganized in a more efficient way. The challenge is to achieve better coordination with our unit with IT, research, and business management. Each year, we champion several projects to improve the quality and management of the clinic. These projects are prioritized in accordance with the guidelines laid down by the Department of Health and the strategy of the institution. The majority of the project's leaders who drive and manage the projects are from middle management, and most are doctors and nurses. The methodology that we are in process of implementing is the Work Improvement Cycle Plan Do Study Act. This methodology is not well known within our organization, and it's a challenge to introduce it. I would now like to talk about some of the projects we are working on. Safety of patients is one of them, and we made a review and structures took place, highlighting that there was no system in place to proactively manage patient safety incidents. Hence, a new classification was implemented, and we have observed that it's more challenging to establish causes and actions in mental health than in general hospitalization. So, what do we mean by a patient with severe mental disorder? The criteria for chronically ill patients in mental health are more difficult to establish than in somatic hospitalization, as illustrates the picture. We are focused on improving care for these patients. Also, we launched a process standardization of individual patient care for those suffering from severe mental disorder. The actions we took include a desk review of NICE guidelines, followed by a debate of these guidelines with our professionals, resulting in a consensus document. The early detection of symptoms suffered by psychotic patients has shown to be useful in improving the prognosis of the illness. The first PDSA cycle took place within a pilot area, and the results showed an improvement in the detection and reduction of the dropout rate. We are now extending this program to all our area. Lights on Rights is a reflection focusing on actively promoting people with intellectual disability in the community. The project provides a response to the need for further progress in the full equality of rights. And this project is part of Erasmus Plus, a strategic partnership of the European Union. We are concerned also by the variability of the portfolio of our services and are working to reach an agreement with the heads of 4 partial hospitalization units. Our objectives include defining the priority services based on scientific review and perceived needs, standardizing the content, and establish metrics to measure. It's easier to make progress in reactive work, especially with issues relating to patient safety, than to deliver proactive performance improvement. To support the planning of work and assessment of quality, scorecards were introduced 2 years ago. An example of this is the scorecard that includes metrics on activity, accessibility, effectiveness, and efficiency addressed to the managers of the outpatient mental health services. The implementation resulted in a good score of part of these managers. Together with the Barcelona University, the park is running a postgraduate course on quality and safety, aimed at frontline professionals. We are celebrating our first course this year. We have also published a newsletter dedicated to quality and safety. We made featuring articles on healthcare work and the associated results, interviews with leaders of the clinic, and extracts from scientific literature that are relevant and of interest. So, what are the current quality challenges in our mental health service? Basically, we have two. Firstly, ensuring that quality is firmly on the agenda of the senior leadership team at a time of severe economical constraints in our country. Secondly, making improvement across the whole institution with regards to the methodology of quality. El camino no es de rosas, we say in Spanish, or life is not a bed of roses, as the picture from the Flower Festival in Girona, Catalunya, helps illustrate. But without a doubt, the work of the institution is rewarding, interesting, and challenging for all, keeping us busy. Thanks a lot for listening. Gracias.
Okay, and the next group, I've been privileged and I feel extremely honored to have been a witness and a partner in a journey that's been incredible. In fact, if you have questions about what you'll hear from Amar and James, there's an entire team at the back of the room that are also supporting the work. So help is here in numbers, and we look forward to hearing the story.
Thanks very much, Pedro. Good morning, everybody. My name's Amar Shah. I'm a forensic psychiatrist and Associate Medical Director at East London Foundation Trust.
And I'm James Innes. I'm a pharmacist and I'm head of QI at East London Foundation Trust.
We're going to talk to you this morning about the quality improvement work that's been happening at East London Foundation Trust. We're a provider of mental health services across 4 boroughs in East London. We provide forensic services to a slightly larger catchment area of North and East London. We have some dotted services, satellite services across London. And for the last year, we've also been providing mental health services to Luton and Bedfordshire, completely outside London. We also provide non-mental health services to 1 borough in London. So in total, that's a population of 1.5 million people. Any improvement work needs to be grounded in the local context and the local narrative. The community that we serve has some of the most cultural, economic, socially diverse and deprived areas of England. We have a complicated commissioning structure that makes a single approach to quality quite challenging, but we have a bedrock of sound finances and robust assurances that make this all possible. 3 or 4 years ago, we started to set out on a new direction. If you come into East London Foundation Trust, this is what you will see on the wall. It's an indelible statement of intent about our strategic purpose as an organization, aspiring to provide the highest quality mental health and community care in England, and how we want to support our staff and service users to do that through continuous improvement. Of course, doing that nurtures things in an organization like shifting the power balance to the front line, changing the balance between assurance and improvement, becoming more listening and learning, and fundamentally putting patients, carers, and families at the center of all that we do. Before we started any of this work, though, we spent some time, several years really, preparing the ground, getting the context right for this. Things like making sure we had stable, credible clinical leadership in place, making sure we changed the way we recruited and developed our nursing workforce, making sure we had sound finances, low vacancy rates, and good bed management. And that's the bedrock for this improvement work.
Now, as Amar said, we started our quality improvement program back in February 2014, but we spent a lot of time before that building the case for change. That involved visiting other organizations, talking to the board and teaching them very early small-scale tests using improvement methodology, and also appointing a strategic partner who were the IHI. So this is our case of change. This is our driver diagram that we're using for the entire program. And I guess what you'll notice straight away is we're not just focusing on QI projects. We're focusing on building will in the organization, building improvement capability, ability at scale and pace, and also making sure that this is actually business as usual. So what are we doing to build the will? Well, we have QI teams go to the trust board and tell stories about what they're actually doing. We send out electronic and paper newsletters to over 5,000 people every month. We graffitied the ground floor of our trust headquarters with this visibility wall so people could really see what was going on. And I guess one of our main things is being our QI microsite. This is our one-stop shop for everything to do with QI. It's seen over 100,000 views in just over 2 years. And going on from there, it's been really, really great because as more projects start to see results, we're starting to publish them. 12 QI projects submitted for publication. And it goes on from there as well. So we've had 12 national submissions for awards being shortlisted, of which we've won 5. Fantastic stuff. What about building capability? So we're not just focusing on one group's staff or another. We are looking at every level of the organisation, whether that's our service users and our patients and their carers. Maybe it's frontline staff, all the way up to the boards, both our exec and non-exec directors. And how about support? This is so important. How do we make sure this is business as usual rather than just an add-on? So in the centre there we have a QI team, and around them they have a sponsor, they have a coach, they have access to the QI team, they have forums where they can come together and share and learn, and they also have a lot of resources now so they can see what's going on, look at their data over time and see other projects that are happening. And let's not forget our service users. So our service users are being very much involved to date in governance, but we want them to be involved in improvement as well. So we're really talking about co-design here. And we are thinking about it in 2 levels. Little I involvement, which is we regularly check in with service users on a regular basis to see whether the work we're doing is making a difference. Or what about Big I, where we've got service users either running projects or being equal members of projects alongside staff. Amar.
One of the key principles behind the design of our improvement work is that we let teams work on what matters to them, what matters most to that team and the community and the population that they are serving. It's a really key principle, but it's one that really, we think, helps engage people and make this kind of work feel meaningful at the front line. Of course, across the 155 projects that we've got across the organisation now, they do all align to our 2 high-level aims around reducing harm and providing the right care at the right place at the right time. And beneath that, we have 4 priority areas of work where some, but not all of our projects fit. And we're going to talk you through now some of the data and outcomes we're seeing on these 4 areas of work.
So let's take a look at violence. Really big issue for us at Trust, and in fact for most mental health institutions. And we're really proud to report that we're now seeing a 25% reduction in violence across the Trust. And if you look at benchmarking, we've gone in 3 years from being well above average in terms of violent incidents to either patients or staff to now quite a bit below average. How about pressure ulcers? This is a particular issue for us, providing community services in Newham. And this is a particular issue as well because our staff may only see patients once a week. And we're really pleased to report again an almost 30% decrease in the number of grade 2 pressure ulcers and key improvements and key things like Waterloo compliance, all the way up now to 92%. Access to services, another massive issue for service users. And we're really pleased to report a 16% reduction now in waiting times for our service users, a 22% decrease in the number of people not turning up for their appointments, all in the context of a 19% increase of people coming to see us for referrals. And let's not forget our staff. Staff are the common denominator in all of this. And there's a very, very strong link between engagement in staff and quality outcomes. And we're really pleased to report a real upshift in staff feeling able to contribute towards improvements at work, their motivation at work, their satisfaction, and of course, overall engagement scores.
So in summary, we're still very early in our journey, but what we're trying to do is make quality improvement feel meaningful to our staff and service users. We're trying to make this really difficult work feel possible. We're trying to make this feel valued and permanent through constant and relentless attention from our senior leaders. And we're trying to make sure that people have the skills and the support and the permission to be able to lead change in their own team. Thank you very much for listening.
Thank you, guys. Good job.
Okay, so we've gone to Singapore, we've flew back to Barcelona, we've gone to London, and now we're going to Copenhagen with the Danish Society for Patient Safety and Vibeke.
Thank you very much. Thank you. It's working now. I would like to start to thank Amar for bringing up this challenge for everybody in our team to have this Pecha Kucha running. I'm Vibeke from the Danish Society for Patient Safety, and this morning I'm going to speak about a very important issue for us, which is one of the main areas that we work in within patient safety and quality, namely mental health. Often we hear about Denmark as the happiest nation in the world, and we've been cried out that many times, and when we see why that is, some mention the equal access for everyone to healthcare. But when we look at mental health, do we have equality? We have pure outcomes when we look into the life expectancy for people with mental health issues, which is similar to other places in the world. We have 20-year less expectancy of life for people with mental health issues. So, doing the same thing over and over again and expecting different outcomes, I think is a quote that really put the nail on what are we going to do within mental health. There is an urgency, and we have an obligation to act, which is really important in this matter. And do we know what to do? Yes, we actually have good outcomes in other places in our work. We have improved in acute care. We have eliminated pressure ulcers. We have eliminated a number of hospital-acquired infections. So, of course, we can do similar thing within mental health. So where are we aiming? We want to go to the summit, but mental health is a big issue to improve within. So we started small. We've had a number of things that we would like to work on. Medicines, we want to work on physical health. We want to work on reduction in mechanical restraints. And finally, we also want to prevent suicide. So, what about the method to do that? Our experience from other improvement programs is that the idea of a bundle is very important because it engages the staff. We have a few interventions that you should use in a certain situation. So going for the bundle is one of our priorities. Another priority is also to use the model for improvement. I guess most of you in the room is familiar with that, and I think when we look across the world, it has proven itself to be one of the best methods to improve also within healthcare. Paul Bertalden and Don Berwick designed the collaborative model which we use, and I think this model has also proven, at least in Denmark, to be a very good way to accelerate improvement work. So we have the network with learning sessions and action periods in between where individual teams on clinical units work on how to change the way that they deliver care for patients. Each unit set up a multidisciplinary team that would attend the learning sessions. They have to go back and work with the improvement method, the PDSA cycle, to change exactly the way that they deliver care in their unit with the bundle that we have delivered from the Danish Society for Patient Safety. So, what have we seen so far? One of the areas is reduction in medical restraints, and that is a huge issue in Denmark. There is national goals, but we set up an aim which was much more ambitious. So we have set in September that within May this year, we want to see reduction in 50%, and we have some promising results from the 9 units participating already. So what made it possible for us to do these things? Yes, one of the things was to travel and visit our friends that you meet this morning as well, to go to Scotland, to go to East London, to go to the southern part of England to see how they actually work on the similar things, because this is one of the ways we can accelerate the learning. Another area where we see at least promising outcomes is around medication. The two main things we look at is medical reconciliation and also medical review. We have this example from Aalborg, one of the units where they have some reliable processes now and see some outcomes also. One of the things that really has engaged staff, with whether it's physicians or nurses, is the interviews with patients, to hear the patient voice or the user voice, to learn from how can we really improve if we ask the patients, what does this mean to them? And if it's important for a patient, it's also important for the staff. On the teams in the unit, the patients, inpatients are invited to be part of the improvement team. And when in one of the units here in Viborg, the patients, they suggested, why don't we have a weekly meeting to discuss what is the plan for improvement next week? And they have this nice board where patients put up ideas for improvement within how the unit works. What has been really a challenge for us was also in the Danish Society for Patient Safety to start the work with co-creation and co-design together with patients, as East London also mentioned. So for the first time, we had invited patients into a workshop to design a bundle, which was a bundle on suicide prevention. So Lisa and Christian, two young persons who had several attempts of suicide behind them, participated and gave us their ideas. We've also had the relatives to the patients in the room. They were very eager to come because they want to change things. They necessarily didn't want to change the system. They want to change things for their relative. But working together, we find a way to how can they actually help us co-design the system. Another very important issue for us to use the press very actively. When staff see their own unit mentioned in the press, whether it's a local newspaper or the national television, they feel so proud of the work that they have been doing. And you can actually get all the good stories out in the news. Last year, we first time participated in WHO's World Mental Health Day. We'd asked all patients to pledge on what does dignity mean to them. And this was also one of the ways for us to engage patients and service users more into the work. I would like to stop here with this photo of Lego, because I think perhaps that's one of the best examples on how Danish work has spread across the globe. And I hope that we this morning can also spread and share some of the best work that we've seen in mental health going on currently. So Pedro, the floor is yours again, so thank you very much.
Okay, the next speaker from the Scottish Patient Safety Program has thrown a challenge to this small group to get us to 500,000 Twitter impressions. So the hashtag is MHImprove, Mental Health Improve. And if you do want to ask questions, and we do have a couple of minutes at the end, there's an information DJ, and the hashtag is QFG1. Too many hashtags, too little time. Johnathan, MacLennan.
Thank you, Pedro. So, good morning, everybody. And as we say, the hashtag there is MHImprove. And I checked it just before I came on. I think we're about 480,000 Twitter impressions since the other day. So we're quite pleased with that, to be honest with you. I've got the tremendous honour and privilege first to be here, but also to be part of the Scottish Patient Safety Programme. Up until 4 years ago, I was a charge nurse on the ward. So to be here today is, well, quite surreal, to be honest with you. So when we start thinking about it, we have to start thinking about, well, what is harm? Okay. So quite frankly, this is not nature's way, and this is an operating theatre in Scotland. It is not an operating theatre in Scotland. But when you start thinking about what is harm in mental health, is it different from other services? And quite frankly, yes, it is. You have physical harm, yes, the harm caused by falls and the harm caused by medication, but there's sexual harm that exists there. There's social harm, the stigma of being detained or being taken into hospital. The big campaign run by See Me in Scotland as well, which I would encourage you to look at. But there's also the psychological harm as well. Being restrained, witnessing somebody being restrained. So, this is a bit different. When you're thinking about the stages of improvement, oh, isn't it cute? The stages of improvement. One dog there, he's kind of sitting there thinking, well, I might just sit back and wait and see what happens. The other one said, sod it, I'm going for it. We can't work out if that one there is kind of gone for it, or is he coming back? Is he reticent? Is he hesitant? And the one thing that we've been able to do in our programme is actually be all three of these at any stage. So in our programme, and what we've got is scale. We've got all the health boards in Scotland participating, even the boards without inpatient beds that don't necessarily need to do that. The little bubble in the corner there The big thing for us, and the biggest thing, is service user and carer engagement from the very beginning, at the very beginning of any design of any piece of work in mental health improvement. Now, one thing though, we think we're doing pretty well, and we'll get some results later, but what we haven't been very good at, and what we're hoping to share with this network, is actually publication and getting that work out even further. The networks in Scotland, though, that have been created internally, and that sharing never happened before, and we're pretty convinced it never happened before, and as nurses, we're a pretty Presbyterian bunch. We don't generally say, well, I've done something really, really good, because often we're told it's not very good. And the example, Vibeke, you just gave about going to the press and sharing the good stuff, we have a different relationship with the press in Scotland. So if you're watching, be nice. And it's that sort of willingness to share and that ability to generate ideas that's been at the forefront of this programme. And it's the logical sequence of that the programme goes round and round and round and round, and it's consistent. And it has a logical approach to it as well. And as I say, we've used the model for improvement, but we're looking and exploring other methodologies as well, because if it works for you and it sees an improvement for the patient outcomes, then it doesn't really matter. But at the end of the day, it's got to be logical, and a programme doing this should not be a grueling series of exercises as well. You've got to be in this together. It's got to be a collective approach to actually deliver the results. And when you go back and think about that network, without these networks and that sharing, you become very insular, and it actually slows down. And that acceleration that we've got both nationally and internationally has been one of our key things. So, 4 years ago, we set out with a very small set of things. We could maybe do a bit of this and a bit of that. We now have 25 safety principles, 25 interdependent processes right across from medicines to risk assessment to restraint reduction, that we believe if you do more of these processes than less of them, the outcomes will be better. And we're thinking about it in the system of preventing and recognizing deterioration, because pretty much everything we do round about harm is either a system failure, potentially. It's actually, is it a training issue? Is it just a failure to recognize deterioration from the very, very beginning? So we're looking across the whole of the safety program to do that just now. We have not given, Bob Lloyd better not be in the room, the how much by when bit too much. We haven't given anything a numerical goal. But what we've said is patients should be safe, staff should be safe, and this is the first time in 4 years that we've actually said we are now trying to reduce restraint, reduce violence, and reduce self-harm. And why did we come to that conclusion? It's because the data that we've been collecting nationally has told us to do it. We've seen examples here, and we've got some colleagues from Lanarkshire in the room there. Rischel General Hospital, a 64% reduction in the incidence of restraint. The State Hospital, the high secure hospital in Scotland, 76% reduction in the rate of seclusion. We've got 75%, the numbers go on and go on. This is best in class, and there's still a lot more that we can do. But nationally, and how upset were we that one data point off a sustained shift in restraint in Scotland there recently. So we've got this nationally aggregated data at the moment. What we need to do just now, though, is start to stratify that data, because we find that the more intensive care units tend to pull that median up, and actually rehab is virtually no restraint. So we've got to be very careful how we do it. As we move forward, we've been concentrating predominantly on inpatient services. We're now trying to design a program and scope a program that is inpatient and community, but actually picks up child and adolescent, picks up perinatal psychiatry, picks up pretty much everything else, bearing in mind that 95% of care is actually delivered in the community. So one thing I'm particularly passionate about, and it's not sheep, although that's my school bus and that's my sister, is some of the more remote and rural contexts in Scotland as well. And that makes us start thinking about how we link with other agencies like Police Scotland, like the Scottish Ambulance Service, when we look at transitions. Because one of the riskiest things that we do is that we move people around services. So when we start thinking back over the 4 years we've been doing this work, what advice can we give ourselves, and what advice can we maybe give some of you? Avoid duplication, because it is the mother of all evil. Start small, quick wins. These are all the obvious things as well. But there's nothing wrong with being nice about stuff. But there's also nothing wrong with being very, very brave and making sure that things get done as well. So, wait a minute. There's actually a serious point to this. There is. I'm a mental health nurse by background. I know that I have restrained people that I shouldn't have restrained. I know that I've given people medication that I shouldn't have given medication. And it's actually that, it's not an epiphany, it's just how it is. And I want to look back in 20 years' time thinking, this isn't very good. I want us to be the excellence. I want there to be, all the things in the world that we're not doing now. So are we looking into an unknown future? Well, yes and no. We've been very lucky. We've got excellent support within Healthcare Improvement Scotland and from Scottish Government, but it's from the people in the boards that are doing the work. It's the frontline staff, it's the service users and carers that are influencing this work across the country that have been the cornerstone and the bedrock of the work that we'll be doing in Scotland. And one of the most encouraging things that we heard and saw recently was when we were doing our evaluation, and this is Amy, a staff nurse from an IPCU in Ayrshire and Arran, and she went, some of the new people that are coming through don't even know what SPSP is, the Scottish Patient Safety Programme, but they're doing restraint reduction, they're doing risk assessments much, much better. They're doing all this work because they care, because the compassion's there, and because the will of the country is making it so. Thank you.
Okay, and this is work in partnership, and I'm going to ask the people from Devon Partnership to say hi to us so that people know where you are. Hi, and the people from SLAM. There you are. So this is work that's happening in England. It's happening in partnership, and you'll hear again, it's about reducing violence. So Andrea and Catherine.
Right. I'm the Andrea, part of the Double Act.
And I'm Catherine.
And we're actually from the Devon Partnership Trust, and we wanted to just share with you today how our organisation, in partnership with South London and Maudsley Trust, are aiming to reduce violence by 50% in our inpatient units by September 2017.
So the project itself is delivered in equal partnership with people of lived experience. Lived experience consultants work alongside myself and Andrea in every element of the project, from training to collecting data to speaking with patients, and they give a real depth and perspective at every level. The programme's called 4 Steps to Safety, and it aims to improve 4 areas. We're working with wards and talking to them, helping them to better anticipate events, to communicate well, and to mutually agree the standards and the expectations. 4 Steps to Safety was originally piloted in the South London and Maudsley Trust. They piloted across 4 wards in 2 different hospitals, and they managed to reduce violence and aggression on their wards by 58%. This was then sustained for 2 years. They applied to the Health Foundation for a grant, and Devon were very lucky in that we were invited to test this on each of our inpatient units.
The clinical toolkit consists of, it's a bundle of interventions, and it consists of a communication tool, a violence prediction assessment, a risk management framework, and a structured engagement process. It's the implementation of all of those things together that actually is what's improving things on the wards.
This is the first time that Devon Partnership Trust have had dedicated facilitators. We've heard from many others who have big QI teams. We're quite new in it. So far we've seen obvious positives from it in terms of spreading and sustaining, going from one ward and making sure that that learning is captured. And it also helps us as it means we have the time and the experience in order to face resistance head on.
We're implementing the programme using the Model for Improvement and PDSA cycles. We're helping teams to acquire new skills, to safely test the new tools that we're introducing to them. And more importantly, in some respects, we're actually supporting them to use those skills for other improvement projects.
4 Steps to Safety produces a lot of data. There's a huge variance in data, including outcome measures, balancing, process. What we need to make sure is that this data is meaningful and that it's relevant, not just to all of our staff, but to all of our patients as well. So we provide training on control charts. As an organisation, we're looking at moving towards using control charts in the majority of our projects. And so 4 Steps is a driver in which we can train patients, staff, and carers on both data and PDSA.
It's not very good, that slide, but this is a safety cross showing, it's a chart showing the safety cross data collected by one of the wards. It's allowing them to have a conversation around severity of harm reducing, but it's the positive message that actually these changes you're making are having a difference, you're having a positive impact.
So the programme itself uses a wide range of visual display tools. We've got a safety cross, a ward map, and a traffic light system. Staff are really finding this positive because it means that they can assess risk in real time, that they can be proactive, that they've got these prompts on a daily basis, and feedback is that staff actually feel a lot safer and they feel more empowered in order to act upon these things.
We're talking to teams about why measurement's important. Without it, they won't know that whether the changes that they're making are an improvement or not. We're also working with the teams so that they can take over the monitoring and the measuring for themselves when it's appropriate to do so in this particular programme.
It's too early for us to say any definitive results, other than the fact that there are very early indicators that show this is having a positive impact on each of our units. Positive outcomes around patient and staff satisfaction, positive outcomes, as Andrea said, about severity of harm, and also quality of handover has improved, the quality of the engagement that we have, these things we're all seeing an improvement in.
This is the best bit, because we're actually encouraging people to break with the traditional staff-written rule book that governs patients, controls environments. We're asking people to sit around the table together to discuss values and actually come to a shared agreement about what the standards are and what the expectations are.
Due to the nature to some of our patients, we've had to think outside the box and be quite creative in how we look at engaging with them. So we've got patients from medium secure units, long-term, very chronically unwell patients. So in order to engage with them, we've held things like tea and coffee mornings, patient forums, patient council meetings, and on one occasion using a Meccano robot, which was built by one of our lived experience consultants, in order to get people on board, to have those conversations.
The collaborative events across both of the trusts are allowing the teams to come together and share their learning and experiences. The last one that we had in January was really well attended, and it led to the teams collectively seeking solutions to the problems that they were facing. We also got some commitment from senior managers in terms of how they were going to use the data that was displayed.
So already we've come across a number of barriers, both in Devon Partnership Trust and in South London and Maudsley. Some of these been around lack of leadership on wards, the fact that actually in mental health we're struggling for staffing, there's a lot of agency staffing. So although we train everybody in these interventions, coping with the high turnover of agency staff has been quite difficult. We're now taking a more coaching role to assist new leaders and making sure that everybody's inducted.
I think embedding the programme into governance and supervision structures, getting the clinical leaders involved, having their leadership in the programme, and actually patients involved in testing the new processes, that's what's supporting the programme, keeping it alive.
So it's important to note that this isn't one of those top-down processes. This is something that we are constantly evolving around feedback. We get feedback in numerous different ways, from patient questionnaires, staff questionnaires. We have learning logs on the wards, and we also have a weekly telephone conference where both members of staff from Devon Partnership Trust and South London and Maudsley can ring up, give us feedback, and that's directly influencing our PDSAs.
Moving forward, we know that we need to get better at promoting the project and sharing the information. And that's across both organisations, so talking to each other, but using social media, having a web page. It's no surprise that the patients are actually doing better at that than us in terms of they wrote an article recently about the 4 steps to safety and included it in their carers newsletter.
So we are now around a quarter of the way through the project. We've still got a far way to go. We're confident that as long as we keep learning, that we keep partnership at the heart of everything that we do, that actually we will have positive results. In true partnership,
we can move mountains.
Thank you. Thank you.
Okay, so there's a few underlying messages here as we reflect on the achievements of each of these institutions. We realized that maybe 5 years ago there was very little happening. There were exceptions happening around improvement in mental health services. These institutions are building a movement. I'm sure you're doing terrific work. If you are, share it with us. we've intentionally tried to give mental health more prominence in this event because of its importance. We're all struggling with financial constraints, aging population, and chronic conditions, amongst other things. And mental health, somehow we've detached the head from the body as if it wasn't integrated. So improving mental health services will continue to be vital. Improving physical well-being of mental health users will be vital. And we know about the comorbidities and the relationship between mental health and the physical state as we look into the future. So I want to ask you to give all these groups a huge applause. I think they did a terrific job.